I'm Halima Al-Hamisi from D3 International, a Senior Program Implementation Lead. And for today, I'll be a moderator for this session. Please receive greetings from Zanzibar. I'm here with my panelists. Actually, we're supposed to have 4, but Dr. Mtuli, maybe he will come afterwards. So for now, we have Dr. Slim. Dr. Slim, please wave your hand to the participant. He is the Director of Preventive Service and Health Education, the Ministry of Health in Zanzibar. And actually, he is a champion for CHV. You can't mention CHV in Zanzibar without mentioning his name. Dr. Slim, he is a public health specialist and has well experience on the provision of community health intervention in Tanzania and outside of Tanzania. And also we have our community health volunteers from both regions, Tanzania mainland and Tanzania Zanzibar. We have Sister Doesta, please wave your hand. She's community health worker from Dar es Salaam, mkoa wa Pwani, and she's well experienced community health workers with high performance, and she has a good record of saving the life of mother and children, specifically under 5 children. And also we have Mr. Saif there. Mr. Saif, please. Also, he is a community health volunteer from Zanzibar, Pemba specifically. And also, he is best performer CHV. Always, he has good record from his community, but also for the Ministry of Health at all. So, welcome, my panelists. In this session, we'll focus on the integration of community health workers into national health system. Also, we will hear opportunity, challenges that come along with, but also we will have the opportunity to hear the future plan in both region, if possible. I mean, Tanzania mainland and Tanzania Zanzibar. We at D3, we are very pleased to have the government representative from both mainland and Tanzania, but also to have CHV from both regions. We are very happy to that. And today we are looking to explore our milestones that have been achieved through sharing experience for implementing digital supported community health workers program. Let me give you an overview of digital health improvement in Tanzania. For nearly 20 years, D3 has been working in Tanzania to change the way people experience care. We are working in collaboration with government and community to leverage digital and data to create a stronger primary health system. But for the last 3 years, D3 has been partnered with the Ministry of Health Zanzibar to develop, test, and scale up of innovative digital enabling community health system called the Jamii Afya. And even our community health volunteer, we are calling them Jamii Afya community health volunteers. Jamini Afya strengthens people-centered care, brings frontline health services to people doorstep, and ensure that all people, especially the most vulnerable, receive support and high quality of care. Since August 2021, the program has been scaled nationally, where a single and unified cadre of 2,300 SHV have been trained and deployed across all the district. I heard yesterday from Honorable Umbi Mwalimu, if Tanzania mainland still you are struggling to have single cadre of CHV, but thanks God, Zanzibar, we managed to do that, alhamdulillah. Currently, all Zanzibar population, they were served by digital equipped community health volunteer at their doorstep. The Zanzibar Ministry of Health has brought the country closer to universal health coverage now, just because of our CHV and some other intervention. But also, DTRI has scaled up this digital health intervention in the Tanzania mainland. So in the mainland, in collaboration with the government of Tanzania, DTRI and Apotheca have been working to address the health system challenge through innovative, first of its kind, healthy innovation that links the three key providers, community health workers, private sector, drug shops, and health facility in fully digitalized continuum of care. The system implemented through Afya Tech program improves the quality and coordination of care and the use of data across the public and the private health system. This is a short summary on how DTRI scale up this digitalization issue and integrate it into Ministry of Health. Just I want to tell you, in Zanzibar, the community data have already integrated into health management system. So if you need any community health data, you can get through our HMIS. To link this statement, now just you can see why we need community health volunteers in our country. Zanzibar, but also Tanzania in general. We are still needing community health volunteers because we are still struggling with a lot of challenges pertaining to health care. We have inadequate resources for health. This is a global problem, but also in Zanzibar, for example, in Zanzibar, the place where I come from, we have shortage of staff for about more than 50%. Specifically now we have new hospital, we need more staff. But also we have poor referral systems resulting in a poor health outcome and avoidable death. But also we are suffering from cultural beliefs and misconception, specifically for maternal and child health. But we believe that CHV, they are a trusted member from their community, and they can resolve this cultural belief easily rather than healthcare provider. But globally, there is significant that if we are using community health volunteers, first of all, is a cost-effective compared to healthcare provider. But also they contributed a lot on improving primary health care. Once if they are trained, equipped, and well paid, they can help us a lot. We are just trying, but we've seen the achievement. We are also struggling with the problem of inaccessibility of health services, specifically for marginalized and vulnerable groups. So most of maternal and child indicators are not reached. For example, now the indicator for nutrition in Zanzibar, our data said like 60% of the pregnant mother, they are suffering with anemia. All this happened due to malnutrition, maybe, or poor nutrition. or poor diet. But also still, we have imagined and reimagined disease outbreak. We have COVID-19, but also sometimes Ebola and other diseases. So, at this juncture, let me welcome my panelists again, and starting to ask a few questions to Dr. Slim. Dr. Slim, wake up, please. I know you are champion for community health volunteer in Zanzibar, but for community health intervention in general. Can you tell us the contribution of community health volunteers on improving health for the population of Zanzibar and improving health sector in general?
Yeah, thank you, Halima. Thank you, everybody that's here. To be honest, Halima has already made a foundation on the importance of this health cadre in Zanzibar and per se for low and middle income country. Zanzibar alone has a deficit of approximately 49% of our healthcare workers. And when I say that, I mean nurses, doctors, and the rest of them. Having CHV is a direct proportion to kind of lessen the burden of providing care for the nurses, which will allow them to attend into those most robust or rigorous innovation that the patient can come. But Halima has really outlined clearly that Zanzibar, with our context, due to economic and other parameters, which give people hindrance in terms of social determinant of health. So CHV become like a trusted neighbor within the community, who really get to know the community and the context where they live. So going as to them, to the community, we really don't know their context. I will use an example. For example, when we, around June, July of 2021, in Zanzibar, we had abruptly of a measles outbreak. When measles come along, we start witnessing people dying, and children who are either semi-dose or zero dose begin to die, and we got to the level of 16 deaths within the period of less than 3 months. And then we sat down during that time. We had an opportunity to have a polio eradication campaign. I sat down with my colleague to chair and making sure that we got to integrate measles and polio together with vitamin A, because majority of those kids that were dying, they were either underdosed or malnourished. So we believe vitamin A is a precursor for immune system. So we use that platform to cascade our intervention. Furthermore, we use CHV to really go and do what we call behavioral science, because to have effective public health intervention, you require a social intervention and biomedical intervention. And social intervention is the one that actually make people feel okay to be vaccinated and why they're taking the vaccine. And the only people that we could trust to able to display that message was CHV. So having said that, when we went out there to intervene, it was much easier, and we got that community ownership in acceptance of our vaccine. And within less than 4 weeks, we begin to see a drastic fall in a prevalence of new cases of measles. And right now, Zanzibar has just been awarded a certificate from WHO as one of the measles-free destination. So this is one of the achievements. If we could just pack up and go with our cold chain supply, house to houses, we won't be let in by the community because they don't know. They don't know. So this health card, for me, is more like the front battalion for health. And without them, in the context of Africa and other low and middle income country, we will fail our way. So we must adopt them, and honestly, a small way of connecting a primary health care baseline down there in the pyramid. You must have CHV right before you go to the health facility, because this should be the first point of contact. And I do believe if we can all take a test at home using Rapid, I don't know why CHV cannot do that. There is no need for a patient to go and distract nurses who is overloaded at work just to do a rapid test for HIV and malaria. But then if you find out you got malaria, yeah, and you got other stuff, and you should be able to know what to take as well. So these are the stuff that really CHV, when they are fully trained, they need to be doing. And when we do that, we will only see people and attend to the nurses and make our nurses more effectively and efficiently, because not everything requires nurses attendance. So when we don't have enough capacity of specialized human capital for health, we really need to be innovative enough. And I think CHV is the right innovation to the way we are right now. And if we are to succeed in terms of delivering healthcare and reach the last mile, we really have to focus on this cadre. If that's not enough, Zanzibar, Halima has explained that we have a lot. We have a lot of problems, just like anywhere you are, in terms of maternal mortality. But let's look at the driver. On what drive to maternal mortality? We know hypertension is one of them, but also nutrition. They become the driver. And with the less resources that we've got in Zanzibar, it is through this CHV that is identified to us. In northern part of Zanzibar, women who are having complication of pregnancy and delivery are associated direct with nutrition, where when you are in the urban side, it's more hypertensive. So now we got the resources for the right place in the right context. We don't want to make one universal approach to this. So without this data they're collecting, we wouldn't be in a position to make those decisions, right? So again, I emphasize the important notation of this health cadre to make sure we go and actually reach the goal of universal health coverage for at least in Zanzibar. But I do believe we have a lot to learn from this individual compared to countries such as Rwanda, which has got probably same a spectrum of healthcare cadre, right? But then they compensate their effort using this CHV. Today, Rwanda is the only country in sub-Saharan Africa which is closer to SDG 2030. If we mimic what they're doing, take into our context, I'm sure we won't be far from it. Thank you.
Now allow me to introduce Dr. Tumaini. Dr. Tumaini is Assistant Director of Health Promotion Service in Tanzania mainland. And actually, also I can say the champion for community health worker, because health promotion is a place where these community health volunteers are coordinated. So he knows in and out about HIV. Dr. Tumaini, we had a lot of things on achievement about community health program from Zanzibar. At this junction, we want to know the challenges for this program, I mean community health volunteer program in Tanzania mainland. Yes.
Thank you very much, moderator, and the floor for giving me an opportunity. My name is Dr. Tumaini Haonga, as have been introduced, Assistant Director for Health Promotion Services in Tanzania mainland. I appreciate for giving me an opportunity to touch on the challenge with regard to community health programs, as well as where we are envisioning the government. Different from our brothers and sisters in Zanzibar, we are using the term community health workers, while they are using community health volunteers. So we have CHW and the CHVs. So in our write-ups and different documents, you find we are writing CHWs, but we are referring to nearly almost the same thing. And so in Tanzania mainland, as it is for Zanzibar and other countries, mainly in Africa, we are also taking an opportunity to make use of the community health workers in implementation of primary healthcare programs aiming to achieve universal health coverage. This is in the areas being supported by the community health workers, like supporting health education roles at the community level, household visits, linking communities and health facilities, but also supporting basic promotive health services at the community level. These community health workers have been used in different interventional areas, like supporting communicable diseases, non-communicable diseases, but also emerging and re-emerging disease conditions, as well as aspect of reproductive, maternal child health, family planning, sexual reproductive health areas, and other component of the social protection and the basic social services at the community level. So on the side of the mainland, the program has been faced by several challenges, but the main key challenges are three. The first is on the aspect of coordination, which is linked to the second challenge of fragmentation, of which you find these community health workers are not well coordinated in some of the areas. That has been for a long time. On the aspect of the manner how they are trained, the number of days for trainings, but also how they are being paid, those disparities, provision of the working tools to support their roles. There are some disparities depending on the vertical programs and the one who support the programs. But in the same regard, we have the challenge of sharing information to the large scale to what the community health workers are doing. And so we have some best practices in this area. For instance, moderator, through the D3, the Ministry of Health has been implementing the AFIATEC program in the coast region, which is 40 kilometers from here, in the two districts of Kibaha, TC and the DC, where we have made use of the management information system to support community health workers' roles. In linking the project is being done in a tripartite mode, where we link the communities, health facilities, but also the accredited drug distributors, the ADO. But then their roles, implementation, and reporting, including data, are being channeled through the management information system, which we have studied it and consider to think about integrating and scaling it up to other parts of the country as a best practice. Since currently, the government is envisioned to have a new program, which is an integrated and coordinated community health worker program, which is going to address all the challenges I have mentioned. And this program is due for starting implementation. All necessary arrangements have been in place, in collaboration with the PORALG, President Office, Regional Administration of Government, development partners, and implementing partners, of which this program will address the challenge I said. The key issue with the program is implementation in an integrated manner, where community health workers will not only be specific for one interventional area. So the deployed community health worker will support a variety of health areas in the said catchment area. And in that regard, we do not expect that we will have one community health worker who is having a tablet, like a tablet for malaria, a tablet for TB, a tablet for HIV, a tablet for family planning. But then those 4 tablets will save 4 community health workers under this program instead of saving 1 community health worker. And also, regarding the training, we are standardizing training to have them trained for a cumulative total of 3 months, so that they can save variety of areas. And in the case of payment, we are in this program, they are going to be paid monthly incentives, which is standardized, and the ministry is going to issue a government circular regarding the community health workers' scope of work and the practice, and other key issues like the modality of payment, amount to be paid, aspect of training. And in a nutshell, for instance, our data shows to train one community health worker, previously you could find some programs could cater for about 4 million and the like. But through this approach, we are going to lower the cost to 2.3 million through the training which is being underway. So this will support government effort and the area supported by partners to address the challenge in the community health practice, mainly to promote social behavior change, community linkage, and deliver health promotion initiative, and other aspect of basic curative services at the community level, where the community health workers will be supporting this initiative, but under supervision of the skilled health workers from the catchment health facilities. So this is how we are envisioned, and currently we are continuing with advocacy, but also disseminating the detail of this program to different stakeholders so that we are in one page and move together to implement this. This is also a global call to strengthen community health programs to achieve universal health coverage. Thank you very much, moderator.
Thank you, Dr. Tumaini, for sharing challenge, but also you add some achievement. And now I think the audience will know that community health volunteers, they are doing a lot and they are saving the life for our population. Community health volunteers, they're providing like risk communication and community engagement, but also they are doing like community-based surveillance, specifically during the outbreak, but also they are facilitating referral, especially for those who have a danger sign for mother and under 5 children. But also they help us to link between healthy facilities and the community. But also community health workers, they are the one who identify the most of the outbreak in the country. If we take into example, when we got the outbreak of measles in Zanzibar, the first case was reported by our community health volunteers. So you guys are doing a good job. Thank you very much. And as I have told you, today we have our community health volunteers from both regions, Tanzania mainland and Tanzania Zanzibar, so that let's hear from the horse mouth now. Bwana Sefu, habari? unajisikiaje kuwa hapa?
Habari njema na najisikia vizuri kufikia hapa.
Sawa. Tumesikia mazuri mengi ya kwenu ambayo yamezungumzwa kuhusiana na utendaji wenu wa kazi, lakini vikwazo ambavyo vinakumba wizara, kumba wadau mbalimbali katika kuhakikisha hii program inakaa sawa na mnaweza kufanya vizuri. Na najua mmefanya mengi mazuri huko mlikotoka. Je, unaweza kushare successful story yoyote ambayo umefanya au umetoa huduma kule katika jamii yako kutoka kuweza kuambia audience hapa wako kusikia?
Ndio.
Karibu Bwana Sefu.
Asante. Kwanza awali ya yote sinabudi kumshukuru Mwenyezi Mungu, muumba wa mbingu na ardhi, lakini pia akatujalia afya njema tukafika hapa tukiwa wazima. Lakini kwa kuendelea tu labda mimi niseme kwamba community health volunteers tuna mchango mkubwa katika jamii, katika kuhakikisha kwamba jamii za Watanzania zinapata afya bora. Mimi mwenyewe ni shuhuda wa kwanza ambaye nilimkuta mama ambaye ni mjamzito na alikuwa na ujauzito wa miezi minne, lakini katika hali ya kuzungumza naye pamoja na mwenza wake aliniambia kwamba anatokwa na damu, wakiwa wanaamini kwamba ni sehemu ya kupunguza tu katika ujauzito. Wanawake wanasema kwamba anapunguzia, anapokuwa mjamzito akawa anatoka damu katika sehemu zake za uzazi, wanasema kwamba anapunguzia. Kumbe haikuwa kwamba ni kupunguzia. Hii ni moja ya dalili mbaya za hatari kwa mama mjamzito. Kwa hiyo nilichokifanya kwanza, nilijaribu kueleza uhalisia wa kile kitu kilivyo, kwamba hii ni dalili ya hatari na tukiendelea kubakia tunaweza tukapoteza maisha ya mama, lakini pia tukapoteza maisha ya mtoto. Sasa cha kufanya mimi nikawashauri waelekee kituo cha afya kwa ajili ya kupata huduma. Kabla ya kuondoka wao, mimi nikatoa simu ambazo tumepewa kwa ajili ya kutuma taarifa, nikatuma ile rufaa kwenda kwa daktari wa kituo ili aweze kutambua kwamba kuna mgonjwa anakuja kutoka katika jamii ana tatizo fulani. Jambo la kufurahisha sana kwamba baada ya kutumia simu, manake taarifa zimefika kwa haraka na kwa wakati unaotakiwa. Daktari naye pale pale hakuchelewa, akajibisha kwamba amepata hiyo taarifa na yupo tayari anamsubiria mgonjwa afike. Baada ya masaa mawili mbeleni kanipigia simu, kuna mtu amefika hapa lakini yupo na mwenza wake. Nikamwambia jina lake nani, akanitajia jina lake, nikamwambia ndiye sahihi, naomba msaidie. Daktari akaanza kufanya naye mazungumzo, akajaribu kwenda kumfanyia vipimo, akagundua kwamba ni kweli ni dalili ya hatari. Sasa baada ya pale akampatia dawa aende kutumia nyumbani. Alikaa baada ya siku 3, mimi nikapata message katika simu yangu kwamba natakiwa nirejee tena kwenda kuhakiki ile rufaa ambayo nimeitoa. Kwa nilipomrejea mama akaniambia ile tatizo damu imepungua kutoka lakini bado inaendelea kutoka. Nikatoa tena rufaa kwenda pale pale kituo cha afya ambapo alienda ni mara ya kwanza. Alipofika daktari naye pia hakuiweka tena ile kesi, ikabidi aipe rufaa kutoka kwenye kituo cha afya ikaenda katika hospitali ya wilaya. Na alipofika hapo yule mama akabidi apatiwe kitanda kwa muda wa miezi 3. Na actually nashukuru sana, baada ya miezi 3 alitimiza kama miezi 8, akaambiwa tunaomba urudi nyumbani, lakini once ikitimia tu tarehe ambayo umetakiwa kurudi kwa ajili ya kujifungua, usibaki nyumbani na urudi hospitali. Naye pia nashukuru hakuwa mbishi kwa lile, muda ulipofika alirudi na akajifungua mtoto wake akiwa yuko salama na yeye mwenyewe pia yuko hai. Labda kwa hapo mimi niishie hapo, naomba kuwasilisha.
That's a good job, man. Good job.
Asante Bwana Sefu kwa story yako nzuri. Nadhani tumeona how CHV they can save life of mothers and children and how they are doing
very good job at their community. They are struggling a lot. Sometimes they are using their own resources just to make everything to be clear and just to save the life of the mothers. Sometimes they told us they use their own money to facilitate the referral, but that is the good job, and their God will pay you. And now let's hear from Dostia, our community health workers from, every time I forgot the name of your place, Kibaha. Okay. Just tell us, tuambie story yako ya mafanikio katika kazi zako. Tunajua una uzoefu wa miaka 6 katika kazi hii. Bila shaka ushawahi kukumbana na changamoto, lakini na mazuri ambayo umeyafanya. Maybe you can proud yourself, nimefanya kitu kizuri, na unaweza ukahadisia familia yako na pia ukahadisia wadau wengine, na leo tupo hapa tunataka kusikia pia. Karibu.
Asante. Kwa majina anaitwa Dostea Lonjino Lunyungu, ni CHW wa Kibaha, mkoa wa Pwani. Kwanza namshukuru Mwenyezi Mungu kufika mahali hapa. Kama CHW kupitia D3 tunafanya kazi pamoja na Afya Teki. Tuna program ambayo kama CHW tumeingiziwa kwenye simu zetu, ambazo zinatusaidia sisi kufanya majukumu yetu kwa urahisi zaidi. Yaani teknolojia imetusaidia sana. Kwa sababu zamani tulikuwa tunatumia sana madaftari, makaratasi. Unavyoenda kuwatembelea kaya zako zile ambazo unazihudumia, maana tumegawanyika, tunakuwa na zile kaya, yani familia ambazo tunakuwa tunazitembelea mara kwa mara. Imetusaidia kwa sababu zamani tulikuwa tunatembea na madaftari na makaratasi. Ilikuwa ni rahisi sana kupoteza taarifa za mgonjwa, kupoteza taarifa za familia zile ambazo unazihudumia. Lakini sasa hivi kupitia teknolojia za smartphone ambazo tunatumia, imekuwa ni rahisi sisi kama wahudumu kuwa na taarifa kwenye simu, na pia imeturahisishia kutokuwa na muingiliano wa taarifa. Yaani kwamba mimi mhudumu nikiwa tayari nimeshazisajili kaya fulani, inakuwa ni ngumu kwa mhudumu mwingine akipita kuisajili ile kaya, kwa sababu naye kwenye smartphone yake itamuonyesha kwamba huyu mtu ameshasajiliwa na mhudumu mwingine. Kwa pia teknolojia imetusaidia sana kuturahisishia katika kazi zetu. Lakini pia teknolojia pia imetusaidia katika kazi zetu, kwa sababu zamani tulikuwa tukienda unakuwa ile kwa hisia, unahisi kwa akikwambia kwamba mimi na tatizo 1 2 3 na 7 itakuwa tatizo fulani. Lakini sasa hivi kupitia simu zetu, kupitia hii teknolojia, mfumo ambao wametuwekea katika simu zetu, kuna zile dalili za mama wajawazito za hatari utaziona. Dalili za watoto walio chini ya umri miaka 5 za hatari utaziona. Dalili za kawaida utaziona. Kwa hiyo ukifika kwenye kaya ambayo unaihudumia, for example labda nikaenda katika kaya ambayo ina mama mjamzito. Zamani wamama wengi walikuwa na ile mentality kwamba kuwahi kwenda hospitali mapema ukiwa mjamzito, yani zile follow up za mara kwa mara kwenda kliniki huwa hawapendi. Mtu anaweza akakaa nyumbani mpaka mimba miezi 6 ndio akakwambia kwamba anaenda kuanza kliniki. Lakini kupitia sisi CHW, kupitia mafunzo ambayo tunapewa, semina zile, imetusaidia tunapozunguka katika jamii kuwashauri wamama wajawazito. Zile wiki 2 tu za kwanza anapojihisi kwamba yeye ni mjamzito, basi hawahi kwenda kituo cha afya ili aanze kliniki na kumsaidia kupata zile follow up za mara kwa mara mpaka atakapofikia kujifungua. Kwa hiyo imetusaidia sana kupunguza vifo vya wamama wajawazito. Na pia kwa kupitia hii teknolojia ambazo tumewekewa kwenye simu zetu, inatusaidia ninapoenda kumtembelea mama au mtoto, ninapokuta na dalili za hatari, ninapompa referral ya kwenda kituo cha afya, referral yangu inakuwa inafika kule kwa haraka, tofauti na ningemwambia tu aende hospitali yeye mwenyewe. angeenda kule, angeanza kupanga foleni mpaka afike kwa daktari. Lakini ninapompa mimi referral ya kwenda kituo cha afya, tuna masupervisor pale katika vituo vyetu vya afya ambao tunafanya nao kazi, ambao pia nao wana mfumo pia wa teknolojia kama tulionao sisi. Kwa hiyo anavyo message ile inapoingia, anagundua kwamba kuna mhudumu wa afya amempa referral mama mjamzito ambaye labda anatokwa na damu au labda ana maumivu makali ya tumbo. Kwa hiyo akifika pale yule mama, ni rahisi moja kwa moja supervisor kumpokea na kumpeleka kwa daktari kwa haraka na akapewa huduma kwa haraka zaidi. Kwa hiyo teknolojia imeturahisishia sana katika ufanyaji wetu wa kazi. Lakini pia mimi kama kijana pia katika mfumo wetu tunaofanya kazi, tuna vijana adolescents ambao tunawahudumia katika jamii. Mimi naishi Pwani. Pwani vijana wengi, kuna ile mentality ya vijana kutotimiza miaka 18 kwa mabinti, unakuta wanapata mimba za utotoni. Zile mambo yetu ya unyago, mambo mbalimbali ambayo wanafanya kutokana na tamaduni zetu. Lakini kupitia mimi kijana mwenzao ambaye nimepata mafunzo, ninakuwa na ukaribu nao zaidi, na inakuwa kwa uhuru wao tunaweza tukaongea vitu ambavyo kama kijana hawezi kuongea na mama. Yaani namaanisha mfano labda binti akajihisi labda ni mjamzito, au akajihisi labda katika labda vyake vya uzazi labda kuna uchafu anatokwa, au kuna dalili ambazo ni mbaya hazielewi, inakuwa ni ngumu kuongea na mtu mzima. Lakini anapokutana na mimi kijana mwenzake, inakuwa ni rahisi kufunguka na kusema changamoto gani anazozipitia. Hiyo inanisaidia mimi kumcancel au kumshauri kwamba sasa kutokana na tatizo hili ulionao, basi twende kituo cha afya akaonane na daktari. Hii imetusaidia sana kupunguza hata zile mimba za utotoni, lakini pia kupunguza uwezekano wa mimba zisizotarajiwa, kwa sababu tutamwelekeza kwamba family planning kuhusiana na masuala ya uzazi, atachagua njia gani ni rahisi kwake atakayoitamani kuitumia baada ya kufika kituo cha afya, kwa sababu pale atakutana na madaktari ambao watamueleza zaidi. Asanteni.
Thank you very much, Doste, for the good job you have done in your community. Congratulations, both of you. Doste just explained to us how digital health improving the primary health care service by facilitating referral and linkage, and also by data storage, improving data storage. And actually here we are working with a call of action from Liberia. We are insisted to improve knowledge of our community health workers by involving them in a different platform and summit. That's why they are here. Since they came here, they learn a lot of things, and they continue to learn. And also, there is a call of action to recognize CHV. And also we needed to provide the long training to them to help us at least to provide a simple curative and diagnostic service at that particular community. To improve technologies, but also as a government or NGOs, organization, we have to mobilize resources to them in order to be comfortable on their work. Thank you very much. I think we had a lot concerning to achievement, challenges, and also we had the voice from the CHV that they are working at the ground. But now we want to hear about the future plan of Community Health Volunteers Program. We will start from Dr. Tumaini and we will end up with Dr. Slim. Karibu, Dr. Tumaini.
Asante. As I narrated earlier, the future plan with regard to community health worker program, mainly for the Tanzania mainland, we are going to implement the so-called integrated and coordinated community health worker program, under which there are key aspects to community health workers in the areas of training, where we are going to have standardized integrated training, which lasts for 3 months, theory and field practicals during the training, but also 3 months attachment at the village or hamlet level, while being supervised by the supervisors from the health facility and the trainers. That is one. And this training costs 2.3 million for one community health worker to completion. And the other areas is deployment, where we are going to set the standardized monthly incentive to community health worker so that they are paid every month and deliver integrated services at the community level. The third issue is on the information sharing. We are making use of the data, as I mentioned earlier, learning from the feedback and the experience of the systems which were used on local scale to scale up and use them at the national level, countrywide, to improve on the management information system, supporting reporting, data collection, and also follow-up of the implementation of the community health workers. And the fourth aspect is on the working tools. We understand we have the standardized package which defines the key working tools to community health workers, like the uniform, data collection tools, reporting forms, but also mobile applications for storage and use of data in the management information system and sharing. The fifth area is on the continued supervision of the program and in-service trainings. We understand it after deployment, we might need to do some refresher trainings to the existing community health workers, which is also a part of this program. So in a nutshell, the current program aims to address those areas, and the Ministry of Health has been collaborating with President Office, regional administration, local government, as well as implementing partners and our development partners funding the program to implement these future interventional areas. But the modality of implementation, this will be phased depending on the availability of resources, but also on the prioritization of the health indicators at the level of the districts as well as the region. So the mapping has been done, and it is guiding us on the manner of starting the implementation of the program. It will have a national launch by the high-level government leaders, expected to take place in 1st of January next year. So we have 3 months of final preparation to roll out this new program. You're warmly welcome. And in that regard, I also appeal to community health workers and request them to continue executing their task depending on the guidance provided by our counterpart at the local government authorities and implementing partners, while this transitioning is ongoing, and we are going to make sure that those who are in the program are given a special priority to continue supporting communities in the delivery of services. Thank you very much, Darim.
Thank you very much, Dr. Tumaini. it seems the future is glooming, as we are using to say, Zanzibar, yajayo yanafurahisha. So now we want to hear from you, Dr. Slim. What is your future plan of Zanzibar concerning to community health volunteer program?
Yeah, thank you, Halima, and thank you everybody on the floor. Obviously, we have explained earlier on what we have already achieved in both of this CHV, that what they have explained here is enough evidence to allow us to conceive that they are very important to our health system, especially in universal health care. We in Zanzibar, we have 2,300 community health volunteers, and they're covering around 1,000 population. And we plan in our roadmap to increase to double their number, to allow them to really focus on 500 households, so that they will do rather quality work rather than quantity of work. But like I explained to you, right now we have stuff like rapid diagnostics and other parameters that are simply you can able to do it yourself at home. Those parameters, the simple diagnostic, we really try to shift to CHV in order to reduce the work burden to our nurses, so that they can focus on their really core function, which will allow them to provide better service of care. Furthermore, we have already in the plan to really put CHV at the bottom of the pyramid of our health system. So we plan to have community health work at the bottom, and then we will have health facility, healthcare, district hospital. So there will be the first point of referral. We automatically, by doing so, reduce the influx of patient at the facility, reduce the influx of patient at the district hospital, and only those who require referral at the regional and super specialist, they will do so. At the moment in Zanzibar, we had chaos. We had people who just need wound dressing. They're showing up at a referral hospital, which impaired a lot of weight to the service provider in those hospitals, and therefore the service might be compromised. By doing that, the other trajectory, we do expect to see different change of paradigm to allow patient to be addressed, known, like he explained. He identified the patient problem based on his context at his community, and they understand each other in their own language. And then that patient was convinced that he was being cared with the right person, and listen and go to the health facility. The health facility intervened, but the intervention was not enough. They follow each other's up, knowing that case now need to go further up. And this is how we should be doing. And if we continue to do that, automatically everything will change. Our mission and vision in the Ministry of Health Zanzibar is really to lift the barrier for social determinant of health, right? If it's education, we allow CHV to go and give people knowledge. If it's vaccine, we allow CHV to go there and identify those 0 kids and half-dose kids, and we go and intervene. Currently, we have a lot of planning places, right? But without this first battalion, whatever we're going to be doing in terms of biomedical intervention aspect will fail if we don't have the social aspect for them. But like I say, they will do the social part, but we will enhance them in terms of their training to make sure that they do other of those parameters to ensure that nobody is left behind. Yeah. So, but furthermore, we have a roadmap, which is a transition. The government is planning to adopt this health card, right? It's not going to be a CHV anymore. We are planning to make him to be part of the integral part of our health system, and we get recognized as CHW, where they can be stipend and they can able to be equipped and receive proper training to allow them to fulfill their obligation accordingly in high level of professionalism. So we have a frame, and we manage to find resources, even though they are not enough. So we will probably try to seek for more resources to allow this to get benefit, which is correspondence to the service they render to our community. Our country holistically want to make sure we really reach the target of SDG, from vaccine level to reproductive level to other parameter of preventive service, so that we'll have less community going into curative, which is the most expensive and require a lot of intervention for a long time for any government setting. So the way forward, in our way, is to deploy twice as much as CHV in Zanzibar, making them up to 5,000. And Halima mentioned I'm a champion, but no, the minister himself is a chairperson leading to this. I'm just assisting him with the assistance of my deputy director to allow this effective innovation to be able to be implemented in the most effective way and in effective time. So we do believe probably once they have been inaugurated, as per my counterpart there, we will begin to see changes. The changes are already there. What we see right now in terms of maternal mortality, ANC visit, if we could have plotted a mathematical model and take away CHV, this could have been seriously problematic. So what we see right now is an improve, right? But the improved version that require improvement, right? So we really embrace the fact that we have CHV, and I do believe solemnly that this individual are the probably most needed entity in terms of our health system strengthening. And if we train them right and equip them right, having said that they're already committing their own cash to do things, there is inner passion in them already. And believe you me, they're only getting 50,000 shillings, right? And they still stay in the game for over now 3 years. So if we top them up properly, right, and allow them to be more trained, their passion will show, and we will probably be benefited more out of this individual than we can imagine. So with that being said, without further ado, I would like to thank everybody here who participated in this symposium. But I will also like to see if we can able to have more stakeholder to participate in supporting this. The government is having a plan, but it's not ready to fully adopt this health card. And to be honest, few of them have shown an indicator of dropping out. Yeah, we have to kind of keep looking and hire them. And unfortunately, they're human. Some of them die. And we try to make sure we have the same number all the time. And to do that consistency, they really need to be incentivized and make sure they are rewarded for what they are doing. Only then we can have something that is sustainable to ensure that we are reaching the goal and aspiration of our government for universal health coverage. Thank you very much.
Thank you very much, all the panelists. And here is the end of our presentation. We allow a few questions from the audience. Karibu.
Thank you, Halima, for the moderation. I think it has been a very exciting engagement right now. I am Edward Zimbe from Living Goods, and I lead programs across the regions where we operate. So whether it's East Africa, West Africa, and everywhere else we operate. It's such an honor for me to be here today and to listen to what is going on in Tanzania. I have questions for Dr. Tumaini as well as Dr. Slim. And it's related to impact at scale, which is a critical focus for us because in all the regions where we operate, We actually partner with governments, but also partner with other already existing partners to enhance scale through community health work, focusing on universal health coverage. Now he's mentioned, Dr. Tumaini, you've mentioned how there is a plan in January to launch the integrated program on community health. And I'm curious to understand a few things. Firstly, is it completely funded by government, or do we have also partners providing the support? Number two, is it going to cover 100% of mainland, or is it going to start with the two districts, the coastal districts that you mentioned? And then number three, for the integrated package that you're talking about, you've mentioned about them being paid, the training, the supervision, and I just wanted to understand when it comes to the digital tools, because you talked about the information systems, and I wanted to know whether government is leading this or you're working with a partner, for instance, D3, that has got great experience in doing this. Is it something that the government is going to work with? And are these systems interoperable with the DHIS2, the already existing health information system? Is it working together? Just to understand how that is going to operate. And then maybe my question to Dr. Slim with respect to the scale that you're talking about. I just wanted to know whether the government of Zanzibar has already budgeted for this, whether you have timelines for this, and whether all, the digitization is 100%, and whether this is something that the government is going to take on, or you're going to continue, leveraging support from partners like D3. Thanks.
Thank you very much for.
Hello, my name is Joseph Mwashemi. I'm coming from FHI 360 and EPIC project. Thank you so much for a fantastic presentation and the achievement which you have demonstrated in your presentations. I have two questions. One, are there any specific pre-qualifications for these community health volunteers and community health workers? Is it the same or different? I would really like to know on that. And also specifically to Dr. Slim, you have demonstrated that these community health volunteers, they do a great job in community mobilization, community sensitization, referrals and linkages, basically on the social parameters as you have mentioned. But specifically, as you say, they are relieving some of the work from clinical or healthcare workers, nurses. That has been really a challenge to determine, especially from mainland and other places. What specifically task shifting are you shifting from these healthcare workers? If you can give a few examples, apart from the good work which they're doing on community sensitization, linkage, and mobilization. Thank you.
Good morning. Good morning.
Morning.
I'm Queen from Farm Access. The previous participant asked on interoperability, but I just want to be a little more specific because now you're calling on to developing partners and other stakeholders to come and support in all this CHW intervention. But then my real question comes in. You know that when we call up to stakeholders, they all come, everyone is going to be interested. But then how are we going to manage the stakeholders, how to map appropriately, like who is doing what, and maybe try to interlink partners who are doing the same thing? Because we see that as a challenge in Zanzibar, a lot of partners are doing almost the same thing, but NCHW have a lot of fragmented, there's fragmentation of activity. She's nodding because she knows what I'm saying. But it's really a challenge. I don't know how the government can help to regulate because now they are
Asante sana wawezeshaji. So my question goes to, I think Dr. Haonga. We are thinking about this integrated package, a community health worker who will have the whole package, like when there's immunization campaign, the person will work. HIV issues, we'll have to go for it. TB, we have to go for it. Nutrition, we have to go for it. Maternal and child health, they need to go for it. And probably we'll be paying this person, but this person, since he's still a volunteer, may still need to be having some time in his or her life to earn other maybe incomes for his or her living. So do we think this is feasible in terms of capacity and maybe time availability and efficiency? Can't you probably think maybe group or categorize, maybe limit a package? Say maybe this integrated will have 3 components. So that if you are in a village or a street, you may be having 4 or 3. And then note that all of them will be doing similar things. So that you can increase efficiency, but also give time for this person to do his or her work. The other thing, we also thought of engaging some employed middle level, low level cadre of healthcare, like the nurses or the clinical assistants who have a certificate or a diploma, who are still not in the formal public employment system, if they can also do some of the community work, because these people are already trained. You may not need the additional the 2.3 million, so that maybe you can use the available 2.3 million to incentivize more these existing community health workers who have been trained for 3 weeks or a month or 6 weeks, so that they can continue doing the good job they are doing, and the people who are trusted, and they can be retained easily. Swali jingine labda kwa wahudumu, niwapongeze sana, lakini ni ile kuuliza, je, hiki kinachofikiriwa kwamba wewe ufanye karibia kila kitu, ikija chanjo ukashiriki, ukapime watoto uzito uende, kuna kampeni ya kifua kikuu, watafuta watu wamepotea kwenye dawa za kifua kikuu ukawatafute, kwenye VVU au wajenda CTC ukawatafute. Utaweza? Asante.
Thank you. Sorry. Thank you. My name is Eleanor Ochodo from Kenya, the Kenya Medical Research Institute. Now, training, dissemination, and supervision of guidelines is often cited as a challenge to implementing guidelines for treatment and diagnosis for health workers, specialists, and even mid-level health workers. Could you elaborate further on your training, dissemination, and communication activities to community health workers and patients? Because I can imagine if it's a challenge for those who have got the technical expertise, it could also be a challenge to community health workers and patients. Could you elaborate on how you're doing that to effect implementation of guidelines for diagnosis, especially rapid diagnostics? Thank you.
Thank you all for your question. I'm very happy. This seems like you are very attentive during the presentation. Now is the time the panelists to respond to the presentation. There is a lot of questions have been asked here. There are questions about who will support the budget for CHV New Glass, specifically Zanzibar, but also there are questions for Dr. Tumaini. You presented here, you want to do some more inauguration or commemoration for CHV, who will support that budget? And also there are the question, how CHV will be master of everything to provide anything like immunization, healthy promotion, and some such other things, how we will plan our CHV to work effectively. And also other question for CHV wenzangu, vipi tutaweza kufanya kazi zote kwa pamoja na kuweza kufanya kazi zile zikawa nzuri kwa umakini na kwa ubora ambao unaotakiwa, ikiwa kila mtu anatuhitaji sisi. But also there are other questions from the lady there, like how we can map our partners in order to work effectively, to avoid duplication, and to manage our resource. And also, there are other questions about criteria for selection of CHV. I think this will relate both Tanzania mainland and Tanzania Dar es Salaam. Maybe we have different criteria. So you are most welcome to answer the question. Who will start first?
Thank you very much, moderator and the floor. I appreciate for these very good questions and areas needing clarifications. So beginning with the issues raised by Mr. Zimbe on the areas, I start with the aspect of funding of the Integrated and Coordinated Community Health Workers Program. As I mentioned in my prior speech, the funding is both from the government and partners. So all stakeholders are requested to consider supporting implementation of the program. So it's a joint funding, but it is phased depending on the availability of resources, but also the prioritizations of the regions. We have regions and the districts we have made depending on the challenging health indicators. So the regions with more challenge on the indicators are given priorities for first implementation. So that is one approach we are doing. And the detail of the regional prioritization is available for sharing, and we can do that to our stakeholders. Regarding the selection of the district, I think I've clarified this. We are not only going to start with the 2 districts. This is a countrywide plan, and the focus is for the whole country, so different regions, different districts, but in a phased approach. The use of digital tools is expected to be a part and parcel of the program, making use of the current advancement in the technology, but also to simplify receiving information on the implementation part, as well as providing some message and the resource information to community health workers to support them with implementation of the programs. So the digital tools and the management information system are expected to be interoperable so that they will be linked to the other existing systems. And this system, the issue is to reduce the number of systems as well. So the aspect of interoperability is well considered and well featured. In ensuring this, we are working with different partners and other stakeholders, first to start the existing platforms and the systems. And that's why I mentioned that we have established that we have some best practices of the existing systems which can be scaled up. And I provided an example of the AFIATech D3 digital supported system. But also we have other systems like we have other systems in the community health which we can consider them to take some features and have one consolidated system. In the Mr. Joseph asked about the specific pre-qualification. So as I mentioned earlier, we are going to use an opportunity of taking the existing community health workers with experiences and who match these pre-qualifications. But the added criteria for those who have not been in the program is for them to be Form 4 leavers so that they can be part of the selection criteria. To strengthen management of stakeholders and the communication flow, Daktari hapa aliuliza, we have the Community Health Task Force, which is being co-coordinated by the Ministry of Health on one side, President's Office, Regional Administration of Government on the other side, and is composed of partners and other stakeholders. So through this Community Health Task Force, we shall have several technical advisory meetings to inform about the program and advise on the different aspects when moving forward. Regarding implementation of integrated services, the placement of community health workers is at the Kitongoji level for the village, but the mtaa level for urban areas. So in one village, you can have 3, 5, 6, 7 vitongoji, but at a kitongoji level, we have 2 community health workers, male and female. And in population-wise, there will be saving. If a kitongoji will have 1 community health worker, will save 60 to 70 households with an average of 6 people benefiting the same household. But if they are 2, it means they will save 30 to 35 households each for the respective area. With that number of households, if we take an assumption of saving 10 households a day, it means you'll need 3 days of dedicated work by THV in a week. So that is an assumption. And we think, and also studying the ongoing practice, this is implementable and is implementable. But during implementation, we'll have implementation research to start and have evidence on how best the program works, especially on the first enrollment and the intake. So that is the plan in place. Regarding the use of other skilled workers, if who wish to be part of the community health workers, they can enroll in the program. And when they meet the selection processes under the local government authorities, because the selection will take place at the village and the mtaa level and the ward development committees, using the guideline issued by the government. I think I have touched all issues. Thank you very much.
Thank you. And actually, the time is not in our side. Just select one strong question and answer to them. Dear audience, Dr. Slim is still here in the summit. You can reach any time and they will provide your answer. Even our CHV, they will be at their booth there, outside. They will answer all your questions. For the sake of time, just one.
Okay.
Yeah.
Thank you. I probably will touch the question of the gentleman, which also relate to yours. It's a tough job to be able to mimic this professionalism of doing the diagnostic from CHV. But let's be fair. The reason why we're struggling is because we have lack of human capacity, right? This is the way it is. You know, we go to the hospital, our nurses are fully over populated with patients, and where those mothers who require their attention is now being divided to other issue that probably somebody could literally do it at home, right? We test our HIV status in your own home. You can take your partner to the accommodation and test them for HIV and know their status, right? You can able to literally test your own blood pressure, right? And these are the stuff that are happening in the health facility. And probably majority of those people show up crowding the health facility, require those parameters. So we really want to scale up this service to remain at the community level. So that only those who require to go upstream can able to do that. And this means we will have to have some hard conversation with people that probably are aligning to those parameters. But it's more like a trade-off. You either accept the burden of influx of patients to the facility and get poor service, or allow these professional cadre who are dedicated to do what we can do ourselves at home, right? We need to see and learn from our colleague. Rwanda, for example, I'm going to insist. Ethiopia, for example. This country does not have full capacity of the requirement of human capital for health. It is a CHV that has helped them to change drastically their indicator, right? And now when we want to see, when I went to Rwanda and Ghana, I literally watched CHV taking care of nutrition issue, taking care of malaria, taking care of family planning. You know, it's training. You know, when you train somebody, and most importantly, they are coming from exact neighbor. So there is a better chance for the person in the neighborhood to go to the next door neighbor to get cared for. Yeah? But if that's not enough, there is always a woman somewhere in Zanzibar who is pregnant, and she's probably got 2,000 shillings in the morning. That woman has to make a hard decision. Do I use my money to get a loaf of bread, or do I use it to take a bus to the clinic, right? If CHV is within the proximity, yeah, will it be convincing that it can be done without her spending any money? Does it make any sense? So we need to make her choice. And as we venture into a fully fledged health system, maybe by then we can able to say, nah, this can be done by that. But right now, we've seen all these parameters of health are not in the right direction. And one of the reasons should be pointed at human capital for health. And this cadre is a right match to be able to make sure those interventions. So Zanzibar, we are planning to go full scale in terms of malaria, nutrition, NCD, and other parameters that we think they may be able to do with full training. And I think I've touched that, but quickly, when it comes to budget and timeline, yes, we have budgeted and we have submitted to USAID for support, and we are planning to go through a roadmap of 4 years before government can fully adopt CHV into the part of the health system, which will definitely be paid. So we encourage the donor, partner, whoever is interested to really embark on us to make sure we sustain and retain this important cadre so that we can be able to meet our government aspiration and vision to ensure we leave no one behind when it comes to healthcare. Thank you very much.
Let's put our hands together again for the moderator and her wonderful, insightful panel. They did a great job. Wapongeze sana pamoja na CHV. Asanteni sana.